So hello everyone and welcome to another session on a day with me where I'll be taking you through some of the interesting cases of my day. And these are the cases of my hospital, that is TML hospital, that is Tata Motors Hospital. So, so here we have a 20-year-old male with a history of slip and fall with sudden dorsiflexion. On X-ray there was no evident fracture that was seen. There was extensive edema that was seen uh, in the posterior aspect of the foot, and an MRI was advised to look for a ligament injury. And this is the MRI picture of this patient. These are the sagittal PDFS images where we can see that there is extensive collection in the retrocalcaneal bursa and there is discontinuity of the tendoachilles tendon in the distal area, and there is mild edema in the calcaneum. These are the T1 weighted images where we can see that the collection is showing T1 hyperintensity suggesting hematoma, and there is discontinuity of the fibers. On the coronal PDFS images, again we can see that there is collection with extensive edema, surrounding edema in the soft tissue. And these are the axial PDFS images where we can see that there is thickening in the distal tendoachilles with discontinuity, and at the site of discontinuity there is a lot of hematoma that is seen. So this is the report that I had given. There was near complete tear of the distal tendoachilles with retraction of the tendon fiber. So this is very important to be given in the report, the retraction of the proximal fibers. So it was about 3 centimeters from the site of insertion, giving it as Quada type 2. I'll be discussing Quada classification in the next slide, with collection at the site of tear and the retrocalcaneal bursa, which showed T1 hyperintensity suggesting hematoma. There was mild hyperintensity within the calcaneum at the site of insertion, suggesting marrow edema. And some edema was there in the Kager's fat pad and some collection in the tibial joint as well. There was no evident muscle atrophy of the calf muscles, that is gastrocnemius and soleus muscles were intact. So this is very important because tendoachilles is formed by gastrocnemius and soleus, the calf muscles. And in chronic cases of tear, they usually atrophy, and it is important for prognosis of the patient. So coming to the Quada classification, which needs to be mentioned in the report because it will help the surgeon in treating the patient. So Achilles tendon tears may be grouped according to its severity of the tear and the degree of retraction into 4 major types, where type 1 is partial ruptures of the Achilles tendon, that is less than or equal to 50% of the fibers are involved, and they are typically treated with conservative management. In type 2 tears, which was our case, there's complete rupture with tendinous gap of less than or equal to 3 centimeter. This is typically treated with end-to-end anastomosis. In type 3 tear, there is complete rupture with a gap between 3 to 6 centimeters, which is often requires tendon or synthetic graft. While in case of type 4 tears, which is complete rupture and more than 6 centimeter gap is there, it requires synthetic graft or tendon graft with gastrocnemius recession. So coming to my next case, so here we have a 80-year-old female who presented with a mass in the right breast. And this is the MRI picture of this particular patient. So this is the T2 weighted images where we can see this particular mass is largely cystic with a small mural nodule, solid mural nodule. This is because we tried to do biopsy of this particular nodule. So this large cystic lesion with a solid mural nodule, and these are the T1 post-contrast images where we can see that this nodule is showing post-contrast enhancement with some enhancement of the wall. And this is the kinetic curve of this particular patient where the ROI is set in the mural nodule. And this is the type of curve that was seen, that in the early phase it showed peak with washout in the delayed phase. So this is a type 3 curve. We'll be discussing the kinetic curves later on in this video. And this is the ultrasound. Retrospectively, we did ultrasound for this patient, and this is the ultrasound picture where this predominantly cystic mass lesion with a solid nodule was seen. The solid nodule was taking up vascularity on Doppler imaging. So this is the report that I had given, that there was a well circumscribed round T2 hyperintense cystic lesion which was seen in the retroareolar region of the right breast. The lesion was well encapsulated with thick enhancing wall, and a solid T2 hypointense mural nodule was seen projecting into the cystic lesion from the medial wall, and the nodule showed early homogeneous post-contrast enhancement and washout in the delayed phases of the dynamic scan, giving a type 3 kinetic curve, which was suggestive of intracystic malignant breast neoplasm by RADS 5. So no evident involvement of the chest wall was observed. Pectoralis muscle showed normal intensity, and there was no evident ductal dilatation or skin retraction or nipple retraction that was seen. Few subcentimetric lymph nodes were seen in the right axilla, and possibility of intracystic malignant neoplasm of the right breast was given. So this is the MRI BIRADS lexicon, which has to be followed in any case of MRI breast reporting, which specifies the amount of fibroglandular tissue, whether it is type A, B, C, or D, the background parenchymal enhancement, its level and its symmetricity, and in a mass, its shape, margin, and internal enhancement characteristics. In case of non-mass enhancements, we have to specify its distribution and the enhancement pattern. But the important thing here was, in a mass, we have to give a kinetic curve assessment where there are two important phases, that is the initial phase and the delayed phase. And accordingly, the mass is characterized as being benign or malignant. So this is the kinetic curve in case of breast MR. And the curve interpretation is composed of two important sections, that is initial upslope and the delayed phase. The initial upslope is the first 2 minutes, or when the curve starts to change its shape. After that, the delayed phase starts. So initial phase can be characterized as slow, medium, or rapid, and the delayed phase can again be characterized as persistently enhancing, plateau, and washout. The plateau and the washout are the ones that are concerning, because they are usually associated with malignancy, while the persistent pattern is usually benign. Now coming to intracystic breast carcinomas, which are relatively rare and represent 0.2 to 1.3% of all the breast cancers. So they tend to represent papillary breast cancer, can be intracystic papillary breast carcinoma, cystic degeneration of ductal carcinoma, mucinous breast carcinoma. So hence I presented this particular case because it is relatively rare to see this particular type of carcinoma. Now coming to my next case, so here we have a 35-year-old male with history of trauma to the right shoulder, and was not able to abduct his right shoulder. Severe pain and swelling in the right shoulder was seen, and this is the MRI done for this particular patient. So here we can see that there is extensive edema as well as fluid collection, and there is discontinuity of the fibers of the supraspinatus at its site of insertion on these coronal PDFS images. These are the sagittal images, PDFS, where again we can see that particular discontinuity. The supraspinatus muscle is intact, no atrophy. And these are the axial images, where again we can see that discontinuity and some fluid collection around the biceps tendon. So this is the report that I had given, that there was full thickness tendon tear of the supraspinatus at the critical zone of the tendon, along with stage 1 tendon retraction of the Patte's classification. So this I'll be discussing in my next slide. There was that the proximal stump was close to the bony insertion, as we could see in the images, and there was intra-articular and subacromial fluid that was seen on T2 weighted images and PDFS images, and there was no muscle atrophy or fatty infiltration in the supraspinatus muscle. I have discussed what the importance of all these things are in my video on conference discussion. Then the coracohumeral space was normal. Now this is the Patte's classification of full thickness rotator cuff tear. This is stage 1, stage 2, stage 3. So stage 1, there is minimal retraction. So the proximal stump is near the bony insertion only. While in stage 2, the proximal stump is at the level of humeral head. There is significant retraction. In stage 3, there is a lot of traction and the proximal stump is at the glenoid level. So it is very important to give this particular classification for the surgeon to actually plan his surgery as to whether this patient will require tendon graft or accordingly. So this is another interesting case of a 25-year-old male who presented with recurrent hematuria, and on ultrasound abdomen it was completely normal, and on CT urography it showed a clot in the right renal pelvis. So based on that, cystoscopy was done, but they could not accurately identify the source of the bleeding, but they suggested a possibility of upper urinary tract involvement, because in the lower urinary tract they could not find anything, and the upper tract was actually obscured because of the clot. So hence we suggested a CT urography for this particular CT angiography for this particular patient. So this picture is of CT urography first, where we can see that there is some fat stranding around the right kidney, and this particular clot, the filling defect that is seen in the delayed phases. Of course, there is some fat stranding and thickening of the ureter, the proximal ureter as well. And this is Foley's in situ. So he's a 25-year-old male. We did not even suspect possibility of transitional cell carcinoma or any such possibility. And this is the CT angiography of this particular patient, where the diagnosis was clear, as we could see the clot along with tortuous vessels, group of vessels, the lower pole of the right kidney, which was suggesting possibility of AV malformation. So this is a report that I had given. Multiple tortuous vessels were appreciated in the lower pole of the right kidney, which was supplied by the lower porar branch, and a possibility of vascular malformation. In addition to filling defect, possibility of clot in the right pelvis with contrast seen along the periphery, and excretion of the right kidney was marginally reduced compared to the left. There was extensive perinephric and periureteric fat stranding that was seen on the images. So coming to my next case, the diagnosis here is very clear. I just put up this case for reporting. So here we have a 30-year-old female with heavy menstrual bleeding, pain in the lower abdomen. And this is the MRI of this patient, where the uterus appears very bulky with multiple T2 hypointense fibroids, which are seen on these T2 sagittal images. These are the coronal T2 weighted images, where again we can see some mucosal fibroid and multiple intramural fibroids that are seen within the uterus, the bulky uterus. These are the diffusion weighted images, where we don't see any significant restriction within any of the fibroid. So diffusion restriction means early sarcomatous change. So this is the report that I had given. So in this particular report, I have mentioned that the uterus is bulky with multiple homogeneous T2 hypointense lesions within the uterine myometrium, and the fibroid mapping has to be done in any case of fibroids within the uterus. And the mapping consists predominantly of large significant fibroids, where that fundus fibroid, the intramural fibroid in the fundus was a significant fibroid. So I mentioned the location, the size, the characteristics on T2, T1 and DWI with its FIGO stage and sarcomatous feature. So FIGO stage is very important to be mentioned even on ultrasound of the fibroid. And another significant fibroid was that submucosal fibroid, which was symptomatic in this particular patient, and it needs to be mentioned in detail as to size, the T2, T1 and DWI characteristics, the FIGO staging and sarcomatous features. So you can also add post-contrast enhancement characteristics in that particular table if you have done post-contrast of that particular patient. We had not done post-contrast, so that was the table that was made. So this is the FIGO classification of the fibroid, where one is having less than 50% of intramural component. 2 has more than or equal to 50% of the intramural component. 3 is 100% intramural with endometrial contact, while 4 is 100% intramural with no endometrial contact. 5 is subserosal with more than equal to 50% intramural component. Pedunculated subcavity fibroid is labeled as FIGO type 0, while type 6 is subserosal with less than 50% intramural component, and subserosal pedunculated is given as FIGO type 7. So now coming to my next case, where we have a 45-year-old male with severe pain in bilateral hip joint, and this is the MRI done for this particular patient. So again here the diagnosis is very clear. I've mainly put up this case for the reporting. So these are the T2 weighted images. Coronal section, where we can see bilateral femoral head, some effusion that is seen in the left side. Geographic areas of signal alteration with double line sign, which is seen on the T2 weighted images, which is typical of avascular necrosis of the hip. Some joint effusion is seen on the left side. The important thing is extent of involvement, curvature angle, and the staging, the Ficart and Arlett staging. These are the axial T2 weighted images where there is marrow signal alteration along with joint effusion on the left side. So the extent of involvement, curvature angle, and subchondral insufficiency fracture are very important to be reported in any case. So this is the right hip joint where we see the geographic area, well-defined geographic area with double line sign, but there is no subchondral insufficiency fracture or crescent sign. While in the other hip, on these images, we can see that there is a T2 hyperintense signal paralleling the surface contour of the uh, femoral head, suggesting a subchondral insufficiency fracture. And there is a large area, geographic area of avascular necrosis. So this changes the stage of that particular patient. There is marrow edema that is seen bilateral hip along with joint effusion. So subchondral insufficiency fracture is a very important thing that has to be assessed. I have discussed it in my conference discussion video as well, because it changes the staging of this patient. So this is the report that I had given, that loss of normal high T2 signal is seen along with geographic areas of double line sign and bilateral femoral head. But this is the report. In the right hip, I had given the localization with the risk of collapse, extent of involvement, subchondral fracture, and articular cartilage and osteoarthritis has set in or not. Minimal joint effusion was seen with extensive edema. There was no subchondral fracture, and modified necrotic Kerbal index was 41.6%, and it was localized to lateral and central pillars. When you don't know what lateral and central pillar means and what exactly is modified Kerbal index, you can look at my video on conference discussion. So there was moderate risk of collapse in the right hip, giving Ficart and Arlett type 2A. So in the left hip, all the three pillars were actually involved, the medial, lateral, and the central pillar, with a necrotic index of 87%, giving a high risk of collapse. There was a subchondral insufficiency fracture, and hence this type 2B of Ficart and Arlett was given on the left hip. So features were suggestive of bilateral avascular necrosis, right hip Ficart and Arlett 2A, left hip Ficart and Arlett 2B with subchondral insufficiency fracture. Now coming to my next case, so this particular patient is a 60-year-old male who presented with severe shooting pain on the right side of the face since 2 months, and MRI was advised for this particular patient. And this is the MRI picture of this patient. So he was suspected to have trigeminal neuralgia, and these are the axial CIS images of this particular patient, particularly to look for the trigeminal nerve and its compression. So what we can see is on the axial images, we can see this trigeminal nerve on the right side. Patient is having symptoms on the right side with Meckel's cave on the right side. And there is one vessel that is crossing the trigeminal nerve, which is better seen on the sagittal images, as we can see that this loop of vessel is actually crossing the trigeminal nerve at its transition point. So there is a neurovascular conflict. So this loop of vessel is actually superior cerebellar artery. Trace it. This particular vessel is actually compressing the superior aspect of the right trigeminal nerve. On the left side though, there was no neurovascular conflict as such that was seen. The vessel is way above the nerve. So on this cis sequence on 3D, we could diagnose it as neurovascular conflict, which was causing trigeminal neuralgia. So this is a report that I had given, that a loop of right superior cerebellar artery was seen indenting the superior aspect of the sternal segment of the right trigeminal nerve about 4.3 mm from the brainstem. That is 4 mm from the root entry zone is the site of transition zone from central to peripheral myelination. To understand it in greater detail, you can look at my video on conference discussion. There was no signal alteration within the nerve, which was seen on this sequence, which was suggestive of neurovascular conflict. Of course, there were chronic ischemic changes and age-related involutional changes as well. But this was the neurovascular conflict was very important to be given in the report. And since it is in the transition zone, it became very significant in this case. So coming to my next case, where we have a 25-year-old female with knee injury, but there was incidental detection of a lesion in the tibia. And this lesion on T1 weighted images, coronal, this is a large lesion with central area of hypointensity. This entire thing is the lesion in the tibia, and these are the T2 weighted images where the central area appears T2 hyperintense, and this large area again is hyperintense, same as on T1. And this is the PDFS, where that large lesion is partially suppressed on PDFS, and the central hyperintense area on T2 is again seen on PDFS. These are the axial T2 weighted images where again we can see central hyperintense lesion, cystic lesion. So that entire the lesion was incidentally detected on the tibia. She was not having any symptoms, and there was central cystic changes and partial suppression of that lesion was seen on PDFS. So this is the report that I had given: a well-defined expansile intraosseous lesion, which was seen in the metaphysis of the tibia, showed hyperintense fat signal on T1 and T2 with central well-defined cystic area, which appeared hyperintense on T2, hypointense on T1 with minimal post-contrast rim enhancement. Contrast was also done. There was no evident surrounding bone marrow edema that was observed, and there was no cortical destruction or soft tissue component which was seen, which was suggestive of intraosseous lipoma with cystic degeneration. So the learning point here is intraosseous lipoma, even though a rare entity, has to be thought of in case of such lesions which are having a relatively indolent course. The important thing is that it can mimic other lesions in different stages, because she was given a possibility of Brody's abscess in a center outside. But the typical thing that we have read during our UG is the cockade sign. That typical thing will not always be seen. It will have different stages, and in post graduation we should remember all these stages of presentation of intraosseous lipoma. In stage 1, they show homogeneous hyperintense fat signal on T1 as well as T2 weighted images, and they'll be entirely suppressed on stir or fat sat sequences. On stage 2, they show hypointense inclusions on T1, which may appear hyperintense on fat sat T2 or hypointense. In stage 3 particularly, which was our case, they may contain fluid equivalent cavities and signal void bony septae and surrounding thickened signal void rims of sclerotic bone. So it is very important to understand that intraosseous lipomas do have cystic changes within, because outside they had only given the measurement of the cystic area. They thought that surrounding bone is actually normal. So coming to my next case, which is again an interesting case. So she's a 40-year-old female post-hysterectomy status, now presented with mass in the pelvis. And this is the MRI done for this particular patient. So these are T1 post contrast coronal images where we can see a central enhancing lesion with surrounding septations and large cystic component that is surrounding it. And these are the axial sections, T1 post contrast. Central enhancing septations are seen, central enhancing lesion is seen surrounding cystic component. Now these are the T2 weighted images, axial sections, where again we can see large cystic lesion, and the central lesion is also cystic in nature. Some hyperintense signal on T2. These are the T1 weighted images, which show some hyperintensity within the cystic component, which is suggestive of hemorrhage. And these are the T2 coronal images, where we can see this particular lesion along with multiple surrounding cysts and separations. So this is a report that I had given, large multiloculated cystic lesion which was seen in the pelvis, and the lesion predominantly hyperintense on T2 with few areas of homogeneous T1 signal indicative of hemorrhage. On post contrast images, central area shows intense homogeneous contrast enhancement. On ultrasound, we could correlate as to having some follicles within, which was suggestive of residual ovary, and hence possibility of inclusion cyst. Now I'll be showing two questions, and I want you to answer these two questions on the comment section below, and I'll be revealing the answer in my next video. So this is the first case. So he's a preterm child, and this is a cranial ultrasound of this preterm child. What do you think the diagnosis is? So this is the left frontal horn, and there is a cystic lesion that is seen here. So based on these ultrasound pictures, what do you think the diagnosis is in this preterm child on this cranial ultrasound? This is the first question. The second question is 80-year-old female who presented with pain abdomen, and we did ultrasound as well as CT for this patient. And this is the CT picture of this particular patient where we see small hypodense cysts in the liver, and this is the ultrasound picture of this particular patient where we see multiple echogenic lesions with comet tail artifacts. What do you think the diagnosis is?